Okay, Bismillah. Candidate one, are you with us? Candidate one, can you unmute yourself?
Yes, doctor, I'm ready.
Yes, okay. Okay, your first case, 40 years old female patient with headache.
Okay, so I'm presented with sorry,
No. Click once and scroll by your trackball.
I'm trying. Okay, so I'm presented with an MRI T1 for a patient 40 years old presented with headache. I will scroll through the images. Okay, while I'm scrolling, I can see that there is no evidence of acute hemorrhage uh, or any infarction. I can see that there is a low low signal rounded lesion noted within the left occipital horn of the lateral ventricle. Uh, the lesion appear hypointense in T1. I would like to check also the lesion in T2 and the diffusion and contrast, but before that I can't see, there is no hydrocephalic changes noted, no midline shift or brain herniation.
Okay, what is the sequence?
Can I check she's T2?
Can you check again, please?
Sorry, I can see the same sequence, doctor.
Yes, I am asking, what is the sequence?
I would like to see T2 to see the signal in T2.
Okay, where is the exact location of this lesion, please?
I can see that the lesion arising intraventricular from the left occipital horn of the lateral ventricle.
Is it the occipital horn or any other anatomical location?
Yes, this is the left lateral ventricle, and it arises posteriorly and extend to
Okay.
the occipital horn. Yeah.
What's your differential for this lesion, please?
I'm thinking that this may be arising from the choroid plexus, maybe plexus papilloma.
Okay.
The other differential choroid plexus carcinoma, but it will be much aggressive and causing more mass effect.
Okay.
So
What will you do next?
I will check the T2 diffusion and
Okay. Here's the
contrast.
T2.
Yeah, the lesion appear low signal in T2.
No. Just
I'm
click and
Yeah, I have clicked. Yeah.
scroll by your trackball.
Yes, I'm doing that. Okay, so in the T2, I can see the same lesion which appear low in T2, but while I'm in T2, I will also check the vessels to see if there is any associated other abnormalities that I have missed in the previous
Okay.
scan.
Concentrate on this lesion, please. You put choroid plexus papilloma or carcinoma. What
Yes.
against this diagnosis, please?
Because the lesion is low signal in T2 with internal with I think there is also low signal in heterogeneous low signal inside the lesion, which may be fluvoids.
Okay. How will you confirm your diagnosis?
Can I check the post-contrast imaging?
Okay. Here's the post contrast.
Yes. Yes, the lesion shows avid contrast enhancement in the post-contrast. There is no other enhancement lesion, no meningeal enhancement or ventricular enhancement. So yeah, and I think the papilloma will have cystic changes. So I think maybe neurocytoma, central neurocytoma.
This is a
But
typical
it's
location for us.
not the typical location. It will arise from.
Okay. What other differential for intraventricular lesion you know?
Maybe meningioma as well may arise intraventricular. So for I might put this as a differential because it was low signal in T2 and is avidly enhancing. Can I sorry, can I check the diffusion as well to
No
see if
diffusion restriction.
no diffusion restriction? Okay.
Okay, give me your final diagnosis and your management.
Uh, my first diagnosis will be this is maybe meningioma. The other will be Croix-Plexus papilloma, but she is less likely. My management, this is an urgent case. I will notify I will alert the report as a 2-week wait referral for the neurosurgical team. This patient need to be discussed in the neuro MDT. There is no hydrocephalic change, so there is no urgency to call the team. But this patient need to be discussed in the neuro MDT and to have also imaging for the whole neural axis to rule out any associated lesions. I will check also prior
What will be
image.
the associated lesion with intraventricular meningioma, please?
Maybe other meningiomas, multiple
In
meningiomas.
meningioma cases, we do MRI of the whole neural axis.
Not in meningioma because I'm not sure it's a meningioma, but not in meningioma we do.
Consider this lesion is a meningioma. I'm
Mm,
asking. You put the meningioma as your first diagnosis, yes?
yeah,
Okay.
not usually because there is no drop metastasis from the meningioma. But if it's a syndrome, we are suspecting a syndrome, and we can do that.
Like what? Syndrome like what?
Um, neurofibromatosis. Multiple yeah, I think neurofibromatosis 2, NF2.
Okay. What other associated lesion with NF2?
Multiple meningioma, schwannoma, and neurofibroma.
Condyloma. Okay. What other common location for the meningioma?
Meningioma will be extra-axial meningioma, more to be extra-axial. Also, we have parafalcine meningioma and also the other one that arise. I can't remember the name that arise from the temporal anterior to the temporal lobes. I can has a specific name, but I can't memorize it now.
Okay. Thank you. I
And
will
the
comment on.
supracellular also. There's supracellular
Okay, no.
maybe meningioma.
Okay, thank you. I will comment on at the end of the session. Okay.
Okay, thank you.
Next candidate.
Yeah. Assalamu alaikum, sir.
Alaikum assalam. Give me 1 second, please.
Yeah. Should I request control?
Yes, you can request.
Okay.
Your patient is 20 years old male patient with 10 days of sore throat, neck swelling, and difficulty turning his head.
Difficulty turning his neck.
Turning his head or neck. Okay.
Okay, so I'm presented with CT orbits axial section contrast enhanced images of a patient who presented after a 10 days history of sore throat, difficulty turning his head, and symptoms of fever. In my routine practice, I would like to scroll the images once before describing the findings further. I would like to go till the last cut. So this is the last cut. I've seen a quick scroll through the images. I would like to go to the area of interest. I can appreciate that in the region of anterior triangle of neck, there are multiple lymph nodes are noted. Along the left side, there are air foci. There are multiple lymph nodes are noted extending along the vessels as well as the posterior triangle of the right side. There are also lymphadenopathy. The thyroid gland is normally visualized. There are no evidence of air foci within the strap muscles and the neck soft tissues. However, adhere to the sternocleidomastoid, there is smudging of the fat and hazy and blurry soft tissue planes are noted. I'm trying to look for the vessels as well to appreciate any filling defect within them, which is not appreciated at the moment. There is evidence of a left in the region of left parapharyngeal space. There is a heterogeneous low attenuation is noted, extending in the interior part of the in the prevertebral space as well. It is leading to a subtle mass effect on the region of the left parapharyngeal region. I would like to move interiorly. So I would like to see the extent of this ill-defined opacity. I think I'm scrolling downwards. I want to go upwards. So there are hazy opacities in the superiormost extent of the lesion is noted in the region of tonsil, paratonsillar region on the left side. There is
Okay. In the patient complaining of neck pain and swelling, fever, sore throat, what are you suspecting?
I'm concerned about parapharyngeal abscess, and so I'm trying to look for any developing any abscess, but I can see only phlegmon formation in the left parapharyngeal region with multiple lymph nodes. There is no evidence of any collection with enhancing wall, but this I believe this whole area in the left parapharyngeal region as well as along anterior to the spine and along the carotid spaces. This is whole a phlegmon of the as a result of the inflammatory process extending on. There is, however, no extension into the mediastinum. I'm also trying to look for any thrombus within the internal jugular vein. I can appreciate a filling defect within the vessel, so I'm concerned about it.
Which vessel?
Internal jugular.
Okay.
So I'm concerned about the Lemire syndrome as well. I would like to see it in the coronal images.
Leave the mouse, please.
Yep. Okay, so these are the coronal images. I can again appreciate that on the left side, there is inflammatory standing noted. I would like to focus on the internal.
Can you give me your final diagnosis and management steps, please?
So my final diagnosis is left peritonsillar and retropharyngeal abscess with involvement of the left internal jugular vein, suggestive of Lemire syndrome with multiple left anterior triangular and right posterior triangular lymphadenopathy. I'm concerned about this patient because this is a potential space. It can lead to carotid vessel involvement and it can lead to mediastinitis as well. So I would like to see the mediastinal region as well. I would like to urgently inform the ENT surgeon and the ENT department on call. Patient should be put on IV high dose empirical antibiotic therapy, and there should be a follow-up CT with contrast enhancement to look for any liquefaction of abscess for the drainage. I would also like to scan. Sorry, yeah.
What is the causative organism of Lemire syndrome? Do you know?
I don't know. Maybe it's an extension of the same tonsillar. Streptococcus is the most common for the pharyngeal abscess. Maybe it's the streptococcal, but I don't know exactly.
Okay. What complication will you search for in a case like Lemire syndrome?
So I would search for mediastinitis and involvement of any carotid vessel thrombus and any septic emboli to the brain.
Okay, can you scroll through this image, please?
Yeah, so I'm presented with HRCT images, contrast enhanced CT images of the patient, same patient. I would like to give a scroll before describing the findings. There is a widening of the prevascular space
Ignore about the mediastinum. Just concentrate on the lung fields.
on the lung field.
Yes, any complication?
There are centilobular nodules noted in the left peripheral, left upper lobe, peripherally,
Okay.
and many in the posterior, right superior segment of the lower lobe as well. So
Okay.
I'm concerned about these being septic emboli.
Okay, thank you. Thank you. Next candidate. Candidate 3.
Yes, Doc.
Yes. This
So just
patient.
let me give up the control.
Okay, no problem. No.
No,
Wait.
sorry, you can take it.
Stop. Okay. And 3, can you ask for the remote control?
Yes, I will ask. Okay, I ask.
Okay. Cool. Your patient, for any question, I will answer at the end of the session, okay? 5 years old male patient presented with headache and unwell for several days with vomiting. No trauma, concern for intracranial mass lesion. You can scroll.
No.
Click once and scroll. Click once and scroll by your trackball.
But it's not responding.
Okay. Click once and scroll by up and down arrow.
Yes. Scroll. Okay. This is axial cut CT brain for a child 5 years old, concerning for renal for mass. Just I will have a scroll and then I will comment. Okay, I will just go back. Sorry, it's lagging slightly. They are the clinician concern for mass in the brain. Just I'm trying to look for the abnormality, any abnormality.
Okay, tell me your check areas while you are scrolling, please.
Okay. From the beginning, I'm looking for both orbits appear normal, and then when I'm going, I am trying to look for the suprasellar region, and then I am looking in the posterior fossa. Okay. And while I'm going down, I'm looking for the dural venous sinuses. I really couldn't appreciate
Looking for what? Tell me, what are you looking for?
Okay. I'm just trying to look for any abnormal mass lesion. I couldn't appreciate clear mass. I'm just trying also to look for the foramen magnum to search for any crowding or any abnormal mass. I believe that there is evidence of crowding at the foramen.
No crowding.
Okay. Just I am trying to look for both the lateral ventricles appearing normal.
Don't waste our time. This CT brain is normal.
Yes.
How will you manage this case?
I want to look for post-contrast.
The patient is outside the radiology department now.
Outside the radiological department. Okay. Can I look for bone when...
Do you remember the history?
Yes, the baby or the child has severe headache, with vomiting. Yes.
Okay. Patient unwell, headache and vomiting.
Okay. I'm
No
trying.
abnormality within the CT brain.
Sorry.
No any abnormality. How will you manage this case?
I really, if I would in the hospital, I would ask for the post contrast for this baby or for this child.
CT post contrast, okay?
Yes, CT post contrast.
Okay, we did MRI because it is more safe for the patient, and the patient already left the department.
Okay.
You can stop.
Okay. Again, it's not scroll. Yes, start the scroll. Okay. Okay, this is MRI T2 for the same baby. I will just have a look and then I will comment. I can see that there is evidence of abnormal hyperintense signal noted within the right cerebellar fovea and the right cerebellar hemisphere. I'm just trying to look if there is any other abnormality. Okay. Okay. No other abnormality I can appreciate through this. Okay, it's only abnormal hyperintense signal noted within the right cerebellar hemisphere and the right cerebellar vermis. Can I look for...
What are you suspecting?
Really, I'm thinking of according to the history of this patient. It could be infection, could be according to the history also of this patient. Could be a neoplastic lesion, but the neoplastic lesion wouldn't be like this, just taking the fovea. So I'm thinking mainly of infection for this.
Okay, how will you confirm your diagnosis?
Can I look for the post contrast?
Of course. Here's the post contrast.
Okay.
Concentrate on the posterior fossa.
Oh my God. It's not show contrast enhancement in the post contrast.
Oh. Anything else?
I am trying to look. No, I didn't.
Patient now off legs for the last 24 hours.
I'm just trying to...
You will judge the patient by two sequences only, T2 and this contrast?
No, can I look for the diffusion?
What are you suspecting?
Maybe infarction.
Here is ADC.
The ADC.
Give me your final diagnosis, please.
The ADC appears to be hypointense signal, but so no diffusion restriction. So I can compare if this appears to be hyperintense in diffusion, so it would be restricted diffusion and it could be infarction in the
Can you confirm restriction with ADC only or not?
I think yes, because if
okay, give me your final diagnosis.
It could be infarction.
Okay, what is the causes of stroke in pediatric patients?
I'm thinking of Moya disease. Sometimes
This Moya disease will take the cerebellum,
but it will not take the cerebellum. It could be infective infection or
we
emboli.
excluded infection. Thank you.
Okay.
Next candidate.
Yes, sir.
Yes, your patient is 11 years old male patient with fever, headache, vomiting, and instability. You can ask for the remote control.
Okay, so can you please repeat the history?
Okay. 11 years old male patient with fever,
Okay.
headache, vomiting, and instability.
Okay, I'm provided with the axial images of a CT brain of 11-year-old patient. Came with a history of vomiting. I will first scroll from top to bottom and then I'll comment. As I'm scrolling down, I'm able to appreciate that there is a hypodensity seen in the region of the right cerebellar hemisphere, which is involving the cortical region and also the white matter. And it is causing effacement of folia here. Other than this, the ambient cisterns, the cisterns also appears effaced in this location, and there's also some effacement at the level of the fourth ventricle, resulting in the upstream dilatation, resulting in dilatation of the ventricular system, as evidenced by the prominent temporal horns. Now I'm again reviewing the top cuts. Okay. Otherwise, in the supratentorially, I cannot appreciate in supratentorial brain. I cannot appreciate any other abnormality. No any hyperdensity noted. I'm looking in the venous sinuses. The venous sinuses appears slightly hyperdense. Could be secondary to the could be secondary to these all appears do not appears like abnormal. Yeah, diffuse hyperdensity. Okay. And as I was scrolling down, yeah, I can appreciate there is a subtle hyperdensity here in the region. Yeah, here. There's subtle hyperdensity here. I cannot characterize it on this
Ignore
single
about it.
card.
Ignore.
This could be a volume, yeah. So based on these imaging findings, as it is involving the right cerebellar hemisphere, and the first differential could be of a ischemic infarction in the region of the right cerebellum, as it is following the territory of the posterior inferior cerebellar artery. Next, this patient requires urgent CT angiography for visualization of the vessels, and also this patient, I will further refer this patient immediately to the stroke team for management. First, if the patient is within the department, a CT angio should be done.
Patient left the department.
Yes.
Left. Patient left. Left the CT table. What will you do next?
Okay, patient left. Okay. If the patient has left, I will then, okay, after reporting the CT, I have to call the patient again for the CT angio, because this need to be excluded.
Okay. Leave the control.
Okay. Let me just.
Okay. We did MRI because it is more safe for the patient again. So you can stop.
Okay. Okay. Okay, I'm provided with the axial T1 weighted images of the same patient. Again, I will go to the region of interest first, okay, where there's a redemonstration of the hypointensity in the right cerebellar hemisphere. I'm now looking at the sinuses, where I can appreciate there's a loss of signal void in the right transverse and the sigmoid sinus noted here. And on the left transverse sinus appears unremarkable. I'm also looking at the basilar artery here. But yeah, for this I need the T2 weighted sequences, and further the MRV would also be MRV and MRH would also be helpful. Okay, in the T2 weighted sequence, okay, it's not scrolling for me. I am unable to scroll it. Okay, just a sec.
Take your time.
Okay, as I'm scrolling it, okay, I'm observing the bilateral transverse sinuses here, but in this T2 sequence, yeah, I'm unable to appreciate any significant, loss of signal void. Okay, I'm also
Okay.
looking.
You told there is hydrocephalus. Can you confirm the presence of emergent hydrocephalus in this patient?
By looking at the temporal horns, if the temporal horns appear prominent, it is the first sign of hydrocephalus. There is also some effacement of the cisterns on the right side of this mid brain. So it also represents some pressure effect. It also appears to be an emergency here.
Okay. So give me your suspicious.
Yeah, so my suspicion remains same of the right posterior cerebral inferior artery infarct, and for this the patient needs urgent CT
Will
angiography
infarct,
to sorry.
will infarct preserve this folia and anything else?
The infarct can cause the cytotoxic edema. So, in this situation, it can cause, but if the patient does not have any acute history, there's a less likely differential as it is involving whole territory. So, I'm more concerned about. Yeah, okay, now I'm provided with the WI sequence. On the ADC, it is not showing low signal intensity. Would like to see the corresponding DWI image to confirm its diffusion restriction. Okay, and the DWI, I cannot appreciate any significant diffusion restriction. Okay,
Which territory this infarction will take? You are suspecting infarction.
okay, no, but there is some different. Yeah, usually, as it is involving much of the posterior cerebellar surface, so posterior inferior cerebral artery infarcts usually follow this territory.
The whole cerebellar hemisphere.
Mm.
Okay, I will give you the contrast.
Okay.
Give me your final diagnosis, please.
Yes, now looking at.
Anything
It's
else
taking
other
time while
than
I'm scrolling. Yeah.
infarction? Take your time, no problem about scrolling. Take your time.
Okay. Okay. Okay, now I'm looking at right cerebellar hemisphere again in the post-contrast sequence. Where I can only appreciate that there is there is subtle enhancement, leptomeningeal enhancement noted. So if the patient has any history, as the patient was having a history of the fever, the other possibility could be of a cerebellitis here. And in a
Okay, what's
young
your final
patient,
diagnosis?
sorry.
What's your final diagnosis and how will you manage this case?
So as this area was not showing any diffusion restriction, and it is showing a subtle leptomeningeal enhancement on these post-contrast images. So the first differential possibility would be of a cerebellitis. This patient needs urgent neurology referral, and further this patient needs CSF DR for confirmation of infection, followed by the antibiotic coverage.
Thank you. Leave the mouse, please.
Okay.
Next candidate.
Yes, sir. Assalamu alaikum.
Alaikum assalam. Can you ask for the remote control, please?
Yes, I can. Just give me a second. Yeah, I have requested it.
Approved. Your case, 80 years old male patient with 2 days worsening of dysphagia. and difficulty in swallowing.
All right.
Can scroll.
Okay, so this is all right. This is CT brain with contrast of a patient, 80-year-old patient who has presented with history of worsening dysphagia for past 2 days. I'll first scroll through the images and then I'll comment. Okay, so as I have scrolled down from brain to the lower cuts in the neck and upper chest, I can appreciate that there is significant soft tissue thickening as well as areas of ear lucencies appreciated uh, along the paraesophageal region. There is causing some mass effect along the which is extending into the superior mediastinum with mass effect on the left lobe of thyroid gland, which appears to be pushed somewhat superiorly. Now I'm trying to look for any additional lymphadenopathy and any other focal lesion. I'm not able to appreciate any abnormality on the right paramedian side. Visualized vessels are normal with no evidence of any thrombus within the internal jugular vein or the visualized carotid vessels. As of an incidental finding in this limited soft tissue window, I can appreciate that the esophagus appears to be significantly dilated in its distal part, posterior to the trachea, and just distal to this aforementioned mixed density lesion in the region of pharynx and at the junction of pharynx and esophagus. So
Junction of what?
I don't see any calcification on these post-contrast images, but I would also like to correlate it with the unenhanced images if available. In my routine practice, I would also look at the bone window as well
This is
as
post
lung window.
study. This is post
Sorry?
contrast.
Yeah, this is post-contrast study.
You
But
need
in my
to
routine
see
practice,
unenhanced. Okay.
yeah, I will also like to see the unenhanced images.
Okay, ignore about calcification. What's your suspicious of this lesion?
Okay, so in this provided images, post-contrast images of there is a mottled mixed density lesion appreciated in the region of pharyngoesophageal junction with the associated dilatation of the esophagus. I am suspecting pharyngoesophageal diverticulum and with the impacted food particles. So I would communicate my findings to the referring physician and would correlate with any previous imaging if available, and would also advise upper GI contrast study for
Okay.
further characterization.
Can you specify this diverticulum? Which type?
As this diverticulum appears to be extending in a posterolateral direction, this is likely Zenki's diverticulum, and differential possibility of could be of Killian-Jamieson diverticulum, but that are oriented more anteriorly. And for that, I would like to also see the multi-formatted images of the sagittal view, if available.
Vegetal? Okay.
Okay, so I am provided with the sagittal view of the same patient, where I can appreciate the same mottled mixed density lucencies reproduced. And it appears to be, I'm not able to scroll it now. Is it a spot image?
No, you can click once and scroll.
Okay, just give me a second. Okay, no, I'm not able to scroll. Yeah. Okay, I think these are
Unfortunately, no
coronal
sagittal,
images.
only coronal.
Yeah, these are coronal images. Okay, on
Yes.
the coronal images, the similar findings are reproduced, and this mottled density appears to be oriented more anteriorly. as I am not able to see bulk of it on the posterior aspect as I am coming to the vertebral bodies. So
Okay.
the top differential in this case would be of Achillean Jamison diverticulum,
Okay.
which is oriented rather more anteriorly.
Before leaving the CT study, anything else in this patient?
For that, I would
Other than that
in
diverticulum?
sorry, any other diverticulum?
No. Other than diverticulum.
Sorry, I'm not able to comprehend what are you saying.
Any other abnormality in this patient other than
Other than
diverticulum?
that, okay. So can I scroll once again through the images?
You can scroll.
All right, just give me a second. Other than that, I can appreciate the vessels are well opacified with contrast. There is a
Vessels
small
are okay.
sub-centimeter. Yeah, there's a sub-centimeter nodule within the right lobe of thyroid gland, which appears somewhat
No.
hypodense relative.
Anything about the bone?
About bones?
Yes.
Okay, on the bones there is a curvature, abnormal curvature could be appreciated, and I would like to reconfirm it on the coronal view that you have shown me previously.
Okay. We
Okay,
did.
so
You can click and scroll and give me your final diagnosis and management.
all right. So I'm provided with the upper GI contrast study barium swallow of the same patient, where I can see there is a contrast-filled diverticular outpouching from the pharyngoesophageal region, which appears to be projected. I'm not really able to appreciate. Yeah, which appears to be lying somewhat anteriorly. And there is passage of contrast distal to this diverticular outpouching, and there is no evidence of any stenosis or any features of aggressive lesions, and no mucosal irregularity could be demonstrated in the provided images. So yeah, this confirms the diagnosis of esophageal diverticulum, most likely Achillean Jamison diverticulum in a patient with scoliotic deformity of the spine. And I'll communicate my findings to the referring physician and would advise referral to the thoracic surgeon for endoscopic or open resection of this diverticulum, as there is a risk of recurrent infections and halitosis and also dysphagia associated with this abnormality.
Okay, thank you. Next candidate 6.
Yes, sir.
Okay, 75. You can ask for the remote control. Okay, approved. 75 years old male patient coming after fall with head strike. You can scroll.
Sir, I'm unable to scroll it. I don't know.
You are scrolling. Just click once and scroll by your trackball or arrow up and down. You are scrolling now.
Okay, so can you please repeat the history? I'm sorry, I dismissed it.
Okay, 75 years old male patient presented with fall with head strike.
Okay, so I'm provided with non-contrast enhanced CT brain of a 75 years old male patient who presented with the head strike. In this, I would like to scroll the whole stack of images from top to bottom. And in this bone window, in the brain window images, I did not appreciate any gross brain parenchymal hemorrhage. However, I can see subtle hyperdensity noted along left parietal bone in the hyparietal region. And while moving downwards, I can appreciate that age-related cerebral atrophic changes are appreciated in form of dilated ventricular system, as well as extraaxial CSF spaces. Moving downwards, I do not find any hyperdensity in the brain parenchyma. There is scalp contusion and thickening noted in the right frontal region as well, and mild subtle focal scalp thickening is also seen in left parietal region. I cannot appreciate any definitive fractures in this brain window settings. However, in practice, I would
Please,
like to.
all candidates, mute yourself, please.
However, in my routine practice, I would like to check these areas on the bone window images. Moving down towards the lowermost cut, I cannot appreciate any crowding in the foramen magnum. There is no, I want to move upwards. There is no evidence of any hyperdense artery seen in the posterior fossa. Or moving upwards, I'm trying to check for the arteries in the sylvian fissure. There is a subtle hyperdensity in the medial aspect of the left sylvian fissure. It can be a part of the partial volume, but I would like to focus on it more. And subtle hyperdensity can be appreciated in a left frontal lobe as well. So
Anything else?
anything else?
Patient after trauma.
Yes, patient after trauma. Till now, I could just appreciate a small epidural hematoma in left
Yes,
parietal.
okay. What else? What else?
And scalp hematoma in the right frontal region.
Okay, anything else?
Apart from that, I do not appreciate any significant brain parenchymal hemorrhage. There are no tiny micro hemorrhages can be appreciated on this imaging. However, as the patient has presented with the altered consciousness, I would like to go
What
for.
other check areas? Did you check the whole areas of the brain?
Yes, as far I think so.
Tell me your check areas in the CT brain, please.
Check areas are in the basal cisterns and the foramen magnum to rule out any of the herniation.
Okay.
There is subtle hyperdensity noted in right transverse sinus.
Ignore
Which
about that.
Okay, it's not abnormal. And now at the base
Can
of
you
the
look at the orbit, please?
Okay, in the right orbit shows septal thickening with increased lucency in the orbital fat, which can be, and there is fracture noted in the anterior wall of the maxillary sinus. Probably, I would like to see this area on the coronal images if available.
Anything else?
I'm unable to find out anything else.
Look at the orbit. PNS.
Okay. There is an elongated structure noted in the superior aspect of the right orbit, which is associated with the probably enlarged cavernous. I want to see the region of the cavernous sinus, which I'm unable to
Scroll
see.
about it. Bone window.
Okay, in this there is a lag in the scrolling. I'm unable to scroll.
Take your time.
Okay, so in this axial bone window images, I am scrolling
Concentrate
from.
in the area of the orbit and the PNS, please.
Yes, I think I'm going downwards. So I'm moving towards the area of concern. In the area of concern, which is the PNS and the orbit, I can see that there is a mild mucosal thickening is noted in the right maxillary sinus while moving upwards. Okay. There is a fracture noted through the probably through the greater wing of the right sphenoid bone.
Okay.
And
Okay.
yes,
How will you
I
manage
can.
this case?
So considering small epidural hematoma, by concluding the findings of a fracture in the greater wing of the right sphenoid bone and a small epidural hematoma in the left parietal region, which is not associated with any significant bone fracture, this patient should be referred to the neurosurgery department for further management.
Okay. We did CT with contrast for this patient. Please scroll through the image and give me your final diagnosis.
Okay, so this is the post-contrast CT orbits and brain for the patient. The previously described elongated structure in the superior aspect of the right orbit now shows significant post-contrast enhancement, and it is extending to the orbital apex, and no such structure is noted in the left orbit. Within the confines of this study, there is enlargement of the right cavernous sinus, making the diagnosis of the carotico-cavernous fistula in a post-traumatic patient. And
Okay. How will you manage this case?
this patient should be referred to the IR department for embolization of this fistula and further management.
Okay. What types of carotid cavernous fistula? Do you know?
There are, I think, two types, primary and secondary. Primary is with the direct communication with the cavernous sinus and I think ophthalmic artery, and indirect, secondary is with the indirect communications with the branches of the artery.
Okay. Thank you.
Thank you.
And 7.
Yes, sir.
Candidate 7.
Hello.
Can you ask for the remote control?
Yes, sir.
And raise your voice, please.
Hello. Yes, sir.
Yes. Okay.
Am I audible?
Yes, yes.
Okay. Okay.
Your patient, 30 years old female patient, admitted to ICU due to multiple seizures after CS.
I'm unable to scroll the images.
Click once and scroll.
Yes, I have, but okay.
You are scrolling now. Scroll up. Yes.
Okay. Okay. Okay, these are Excel slices of the MRI brain, T1 weighted images. I'm scrolling from cranial to caudal and looking for any abnormality. Okay. At the foramen magnum, there is no evidence of any crowding, and no mass lesion at the CP angles. Ventricles appear unremarkable, and no evidence of any mass lesion. There is subtle hypointensities noted, but I guess these are gyral hypointensities. Okay, next I would like to look at any T2 or flare images.
Where is the T2?
Okay. Yes, on the T2 weighted images, I'm scrolling from caudal to cranial. I can appreciate, yes, there are few gyral hyperintensities noted in bilateral cerebral hemispheres, more in the bilateral occipital areas and hyparietal areas. Next, I would like to look at any
Okay,
post
what are you
contrast.
suspecting?
I'm suspecting cerebritis
Okay,
and
anything else?
uh, mm, um, I would like to
Okay,
look at the post contrast images. Yeah,
looking for what?
looking for any abnormal enhancement and mm,
No post contrast.
okay.
Anything else? Okay, here's the FLAIR image.
Okay. On the FLAIR images, I can appreciate same findings are redemonstrated, and there is more of a vasogenic edema, and
Okay, do you remember the history?
no, sorry. I guess you didn't.
30
I
years
didn't
old
remember.
female patient admitted to ICU due to multiple seizures post CS.
Okay. Right. Okay, this is a vasogenic sort of edema with some um, um, swelling of the overlying gyri, and I would okay. I'm thinking on the line of posterior reversible encephalopathy, keeping in mind the history of the patient.
Okay,
Yes.
anything else?
Um, mm,
Okay,
Sir,
how will
yes,
you manage
here
this
it is
case?
very clear that these are hyperintensities within the finger-like projections, vasogenic sort of edema. So they are in keeping with press. Next, I would manage this patient to control the hypertension. If the patient, this is mostly due to incompetence or non-regulatory function of the blood pressure control. So likely I will um, control the hypertension and conservative measurements.
Thank you.
Okay.
Next one, and it.
Yes, sir. Assalamu alaikum.
Alaikum salam. Can you ask for the remote control?
Yeah, sure. I've requested.
Approved. Okay, your case, 70 years old male patient with multiple falls, confusion, and altered coordination.
Okay. So I'm presented with CT scan axial sections, unenhanced study. First, I will like to scroll through whole stack of images. Then I will start describing my findings. This is a 70-year-old patient who presented with history of multiple falls and now presented with uh, coordination symptoms. I can see that there are some senile atrophic changes noted in the form of intra and extraaxial CSF spaces prominent. There is no hyperdensity noted to suggest any intracranial hemorrhage or subarachnoid hemorrhage. As I go down, I can see that there is an area of hypodensity noted in the left cerebellar hemisphere, also involving the vermis and some part of the uh, right cerebellum. I think there is some lag in the scrolling. Yes, so the hypodensity is involving the predominantly the left cerebellar hemisphere and also the vermis and right cerebellum as well. There is no tonsillar herniation seen, no uncal herniation noted. I will like to see the base of skull also to look for any fractures. I can see that there is opacification of left maxillary and ethmoid and right sphenoid sinuses, which could represent hemosinus in the setting of trauma. I will like to see the
No
bone
trauma.
window to look for any bony fractures.
No trauma. No
However,
trauma. Just fall.
no trauma, just fall. Okay. So, the cerebellar hypodensities could represent infarct. I will like to proceed with the MRI for confirmation and CT angio.
Okay. Use the mouse. Here is the post contrast.
Okay. So, on the post contrast images, I am looking at the vertebral arteries. Bilateral vertebral arteries are normally opacified. The basilar artery is also normally opacified. These hypodensities are not enhancing. As I go up, I do not see any abnormality in the cerebral hemispheres.
Anything else?
Okay. There are also hypodensities in the left sigmoid sinus.
Okay. Then
And there is an opacification of the left mastoid air cells.
okay. Can you gather the finding and give me your
These
differential or suspicious?
cerebral hypodensities are in the non-arterial territory, so these could represent any venous infarction. I am concerned about these hypodensities in the sigmoid sinus region. I will like to proceed with the MRV or CTV or MRV, whichever is available
Okay. Can you
for
look at the
confirmation.
cerebellum? Can you look at the cerebellum at this cut?
Sorry?
Can you look at the cerebellum at this cut? Do you
At
think
this.
this intraparenchymal lesions or extraparenchymal?
All right, these cystic lesions, yeah, they are extra-axial.
Okay.
Yeah.
What's your suspicious in this patient?
These are extra-axial and are peripherally enhancing, so and are seen along the tentorium also. So these could represent any collections, any subdural collections, but I will like to see it on the corneal and sagittal reformate images as well for further evaluation.
The coronal, but without contrast.
Okay. Yeah, so these are along the tentorium cerebelli. These could represent these could represent subdural um, collections.
Okay. How will you report this case and how will you report the clinician?
Yeah, I
What
will
inside
refer
this
this
patient?
patient to neurosurgical team for urgent management. This patient needs a neurosurgical follow-up and close
For
monitoring.
what? What's your diagnosis?
So my diagnosis is subdural collections, as there were some enhancing margins noted on the post-contrast sequences, and there is also some non-opacific there is some opacification of the mesodermal cells as well. I will like to see the bone window also, as the patient has history of fall, to look for any underlying fractures.
Leave the mouse.
If there are no fractures, I will okay. So on the bone window, okay, I can see that there is a loss of the there is some bony erosions noted along the mastoid antrum. These could represent any infectious process
Okay. Leave the mouse, please.
into the subdural collection formations.
We did MRI. I will give you diffusion. Can scroll.
Okay. All right. So these are hyperintense collections noted along the tentorium cerebelli on the DWI images. I will like to
I
see
will
the
give you
ADC to look for the diffusion section.
restricted. Okay, I will give you the post contrast. Give me your final
Oh,
diagnosis and management, please.
okay. So on the post contrast images, I can see that there are ring enhancing, peripherally enhancing collection formations noted along the posterior fossa, along the tentorium cerebelli, and there is also I will like to see the sigmoid sinus. There is some filling defect noted in the region of sigmoid sinus. I am also concerned about the any jugular vein thrombosis in this patient, as it has severe infection. Um, okay, I can see that there is enhancement of the sigmoid sinus, and there are multiple collection formations. And here I can see that there is filling defect noted
Okay.
along the jugular vein.
Give me your final diagnosis, please.
Yeah, so it's an extensive infective inflammatory process involving the left mastoidea cells with posterior fossa collection formations along the tentorium cerebelli. I will urgently convey the findings to neurosurgical team. This patient might need drainage of these collections and Sibacharian sensitivity and antibiotic treatment accordingly.
Okay, thank you. Leave the mouse, please. Next candidate. And it's 9. And it's 9. Okay, next one.
Good evening, sir.
Good evening. How are you? Can you ask for the remote control, please?
I don't know how can I
From up of the meeting, 3 points, click once. Okay. You are candidate 10? Candidate 10?
I can't see the
You are candidate 10?
yeah, I am candidate 10.
Okay. You are controlling now. Click once and you can scroll. Your patient, 40 years old female patient with 5 years history of intermittent headache.
Okay. Sorry, sir. Can you repeat the history, please?
40 years old female patient with 5 years history of headache.
Okay, these are the axial images of the T2 weighted MRI brain of a 40-year patient. History of headache and fever.
Headache only, no fever.
I will go through the images first. No hydrocephalus. Midline is in normal position. I can't see obvious abnormality in these images. So I can see some crowding of the foramen magnum.
Okay.
And I would like to see on sagittal images this image. And there is asymmetry of the ventricle, but no evidence of hydrocephalus.
Anything else?
Mm, I'm looking at the venous sinuses. The sagittal sinus
Okay.
looks normal.
What is the normal appearance of the venous sinus?
Usually on T2 weighted, they shows low intensity. So I can see this right side, but the left side is not clearly seen. Left transverse sinus and sigmoid sinus is not clearly seen, no flow voids. But sagittal sinus and the right side looks normal.
You
So
have?
I would like to see first sagittal sinus, sagittal view.
Okay, here is the sagittal view. T1.
So I can see the tonsillar herniation through the foramen magnum.
Okay.
Mm,
Patient
so this
5 years history of headache.
and the pituitary fossa is engorged, and then I'm looking at the hypotension features, and I can see some sagging of the midbrain as well. This
Okay.
area, and the straight sinus looks normal, but definitely I need to see the contrast enhanced images, so MRV to assess the dural sinus.
Okay, leave the control, please. Here is the post contrast.
Yes, on these post contrast axial images, I can see the thickening of the dura, patchy meningeal enhancement, thickened. Mm. I'm looking at the dural sinuses.
What are you expecting in the dural sinuses in this patient?
They can present with dural sinuses thrombosis. So these features are the overall features are suggestive of hypotension, intracerebral.
Okay, what are the causes of intracranial hypotension?
It can be due to CSF leakage.
Anything else?
Mm.
Okay. How will you manage this case?
Yes, I will give my findings to the referral clinician. This patient need to be seen by a neurosurgical team, and they need to investigate for the cause for the intracranial hypotension.
How will you investigate this patient? What is the cause of?
Yeah, if they suspect CSF leakage, then we have to find out the where, so we can do some imaging for that.
What imaging?
We have to do a whole spine, and we have done already MRI scan, so we can do MR myelogram or CT myelogram or MI scan to see whether there is any CSF leakage, and cystogram. Its name
Okay.
is, yeah.
What did CT myelogram?
Okay, these are the myelogram, CT scan. I can see the enhancement of the CSF space around the spinal canal. I'm looking for any leakage of the contrast. I can see here in between the atlas and the second vertebra. There is some enhancement.
Okay. So, what's your final diagnosis?
So there is a spontaneous CSF leakage in the cervical spine. So this could be the reason for the
Is it spontaneous?
It should be correlate with clinical history. I don't see any fracture.
What is the meaning of spontaneous?
So I didn't see any, I can't see any fractures. So features of trauma.
Okay. Do you know the management of the intracranial hypertension?
Actually, I don't know, but yeah, this need to be seen by neuro people.
Okay, thank you. Leave the mouse, please. Leave the mouse. Next candidate.
Yeah, hello, sir.
How are you?
I'm fine.
Can you ask for the remote control?
Yes, sir, I have just asked for the remote control.
Okay. Leave the mouse. Leave.
Okay.
Who is controlling? Okay. Your patient is 40 years old, female patient with left-sided quinsy drained repeatedly and worsening swelling, dysphagia, neck pain, and febrile patient.
Okay.
Can you scroll? Yes.
Yes, I'm just scrolling. Okay, I'm presented with the.
Raise your voice, please.
Okay, I'm presented with the post-contrast CT scan base of skull. I'm scrolling through the whole stack of images. Then I will comment. Okay. As I'm scrolling, I can see there is some some hypodense areas. I can see some hypodense collection not in the retropharyngeal location. I can also note some air foci. I can also appreciate some air foci within this collection, and it is exerting the mass effect on the pharynx, and scrolling down.
Okay, what are you concerning about?
I'm concerning about retropharyngeal abscess
Okay.
with possible compression on the airway.
Okay.
I'm also looking for the extension of the infection into the mediastinum as well as in the left thyroid lobe, I can appreciate a hypodense nodule as well. as I'm scrolling up. So this is on the basis of the imaging finding. This is the case of, let's say, the retropharyngeal abscess with the compromise of the with the compression on the pharyngeal airway. However, I cannot see any vascular complication, any venous or arterial thrombosis, and I can also appreciate this within this collection some air foci. So this is an emergency finding, and it needs to be urgently referred to the ENT department for emergency management and for the scuration of the airway. And patient should be put on the IV antibiotic, and
Okay. May need surgical drainage. Okay, thank you. Next one, candidate 12.
Hello.
How are you?
I'm good, thank you. How are you, sir?
Can you ask for the remote control? Okay, your patient is 80 years old male patient with right hemifacial numbness. You can score.
Okay, so I've been presented with 80-year-old male patient with hemifacial numbness. Okay, so I'm just scrolling the images. I'll just take a moment to scroll through the images before I start describing my findings. So patient had right-sided hemifacial numbness.
Yes.
Okay, so I can appreciate that there appears to be hyperintense signal seen in the region of the right internal carotid artery. I'm just trying to trace it towards the yeah, so I think I can see in the region of the skull base, I can see that that there appears to be some semi-circumferential hyperintensity in this region. This is highly suspicious for a dissection. I would like to look at the angiogram images if available for this patient to confirm this finding. Apart from this, I would also like to look at any diffusion weighted images in this patient to look for any diffusion restriction in the brain parenchyma.
Anything else?
Apart from that, I'm just trying to I can also appreciate that there appears to be some increased signal intensity in the region of the right on the right side. I think this is in the region of the cavernous sinus, or in the sorry, in the region of the, I think it's in the region of Meckel's cave. Yeah, it's in the region of Meckel's cave. There is some hyperintense signal asymmetrically which is seen. So I would like to look at thin sections of heavily T2-weighted sequences to look for any obvious mass in this region.
What are you suspecting in this region?
I'm suspecting if this could be a neurogenic tumor which is involving the right fifth cranial nerve.
Here is the heavy T2.
I've been given the heavily T2-weighted sequences of this patient. I can see that there appears to be lesion which is seen in this region, which is hypointense. It's displacing the CSF signal in this region, and I think it's causing compression over the cisternal segment of the right fifth cranial nerve from its origin, from the brainstem. I am trying to trace it upwards or downwards. So this is a focal lesion which is seen in this region. Can I see the post-contrast images for this patient to look for any enhancement of this lesion.
Okay, leave them. Okay, here is post-contrast. Give me your final diagnosis and the management, please.
Okay. So on post-contrast images, I can see that the lesion is enhancing. So as I was suspecting that the lesion, it looks like an extraaxial lesion. I'm suspecting it could be a meningioma. Other differentials could be a schwannoma of the fifth nerve. But this is less likely, I feel, because I feel that there is a compression over the nerve rather than it arising from the nerve. But it could be a closed differential. So I would like to refer the patient to the neurosurgical team. The patient would require neurosurgical MDT discussion regarding further management. I would also like to know the clinical and any other previous imaging if available. I would compare that as well. And this should be referred to the neurosurgical team for management.
What could be the management for this lesion?
It could be surgical resection.
Okay, thank you.
Yeah.
Candidate 13 is there? Leave the mouse, please. Candidate 13? Okay, any other candidates with us today? Okay, thank you. We will go for candidate 1. Can you hear me?
Yes, doctor, I can.
Yes, okay. This patient, you presented well, but here the exact anatomical location is trigone of the lateral ventricle. This lesion is hypo intense on T1, also hypo intense in T2. You put choroid plexus papilloma, but against choroid plexus papilloma, no CSF overproduction, not macrolipulated like choroid plexus papilloma. And also carcinoma and papilloma is the same, will not differ more. But here, there is also homogeneous enhancement. You have to put intraventricular meningioma. You put it as first diagnosis at the end. So it was a case of intraventricular meningioma. And this case needs surgical management, okay? It is not urgent, we told urgent, but I think no urgency in this case.
I said I mean urgent to wake weight referral, but no urgent because there is no hydrocephalic changes. Not
Yes.
emergency.
Yes, okay. So other question, in the exam now, you have to finish the case early to leave the examiner to test your radiological knowledge. Because if you didn't do, he will disturb you and finish the case by asking some question for the all candidates. Okay. Most common location for meningioma is supratentorial parasagittal meningioma, and there is other sites, sphenoid ridge, olfactory groove, CV angle, optic meningioma. Okay. Association with NF2, as you told, with multiple schwannoma and ependymoma. Okay.
Okay.
Also, you can put MITS as a
differential, yeah.
As a differential in this case, but this was a case of intraventricular meningioma. Thank you.
Thank you, doctor.
Welcome. Candidate 2. Okay. If candidate 2 not there, but this case she did it very well. It is a case of Lemierre syndrome, and there is partial thrombosis of left internal jugular vein, and the causative organism is Fusobacterium necrophorum, which is gram-negative bacteria. Complication for this case includes septic emboli. Here's the start of the septic emboli on the left lung field. There is nodule here. Okay, may cause dural venous sinus thrombosis. The management IV antibiotics and the coagulation therapy may need surgical drainage if the abscess persists. Okay. Candidate 3,
Yes, doctor.
yes, we give you CT. Okay, not all the CT will come abnormal, but if the patient unwell and clinical history is not going with the image, we will not let the patient to go. We'll do MRI, okay? Like any patient of stress fracture, like you did it for the patient, the plain radiograph is normal, but the patient is in severe pain. So you have to proceed for other modality. Here in the MRI, there is hyperintense signal. You described the case very well. You go for contrast, no contrast enhancement, but you go for diffusion. There is restricted diffusion. I give you the ADC. If the ADC is hypointense signal, this means there is diffusion restriction. Okay.
Yes.
No need to see the DWI.
Yes.
Okay. There is
Okay.
multiple areas of restricted diffusion in the right occipital region, right cerebellar hemisphere, and also there is some dot here. So it is going with ischemia, stroke of the child. Okay. I asked you for the causes of the stroke in the child. Mostly it will be due to vasculitis. Moya will present on supratentorial, okay? Because Moya it's supratentorial occlusion of the both internal carotid and multiple collaterals, which give a buff of smoke appearance on angiography. So the first cause may be vasculitis. The cause of vasculitis may be viral disease, maybe sickle cell disease, or anything. Maybe embolic also, like patient with congenital heart disease, or blood clotting disorder. But the most common cause in pediatric patient will include vasculitis. And if there is supratentorial ischemia, you have to think about Moya disease. Okay.
Okay.
So it was a case of acute cerebellar stroke in a pediatric patient due to vasculitis. Okay, thank you. Next candidate,
Yes.
candidate 4. Yes,
Yes.
I give you the case to learn from the previous one, but you go with the same differential. But here you see there is swollen right cerebellar hemisphere, and you was told there is mass effect, okay, but you can still see CSF here. Basilar artery is still present. You can see the fourth ventricle slightly compressed, but not so much mass effect. So I don't think this patient will need intervention, okay, because not so much mass effect here. Okay, you have to put the differential for stroke, but not taking territorial tributaries. You can put Lermid-Daclus disease, you can put cerebellitis, you can put lymphoma, but lymphoma will come in adult patient. Okay. We go for diffusion, no diffusion restriction, which exclude stroke. Okay. Also, post-contrast study, no so much enhancement. So it was a case of acute cerebellitis, and this case mostly also viral infection. This case will be managed conservative and maybe self-limiting case. Okay. Next candidate, and 5. You did this case very well. You detected the abnormality here. There is on CT. I'm just scrolling to the area of interest. Okay. There is mottled appearance here along the left side of the neck, medial to the carotid, left carotid sheath. It is pushing the cricoid cartilage anterior, slightly encroaching on the airway. This is the anatomical location exactly of the esophagus. If you go down, this is the trachea and this the esophagus. The other finding I asked the candidate for about it, there is marked scoliosis of the dorsal spine, and if you look for the subcutaneous tissue, you will find multiple nodules. I don't know, candidate 4 is with us or no? Okay, so in this case, all left Killian Jameson diverticulum of the esophagus and known case of NF1 with marked scoliosis. If you faced in the exam plain radiograph of the chest and you find marked scoliosis in young patients, you have to put NF1 as differential for your case. So we did confirm the diagnosis by oral contrast. Differential for this case is Zenker diverticulum along the Killian dehiscence, but Zenker will be posterior. Okay. Next case, this case, candidate 6, are you with us?
Yes, sir.
Yes. This case of trauma, you have to check the mastoid, you have to check the orbits, you have to check the sinuses, and you can see here there is air fluid level and the hyperdense content, which means hemocyte, and also here in the right sphenoid compartment. So you have to suspect there is hemosinus, and you detect, when I asked you to look at the orbit, you detect the superior ophthalmic vein engorged. In the case of trauma with sphenoid sinus fracture and hemosinus, you have to put the possibility of carotid cavernous fistula. Okay,
Yes.
so you have to ask for bone window to detect the fractures, as you do. That, yeah, you don't need so much. You take so much time in the patient in the case. You have to rapidly do brainstorming what could be this case, and then ask for bone window, and then for post contrast study. Post contrast will give you the diagnosis. The superior ophthalmic vein is enhanced on the arterial phase. Okay, so which means there is fistulous formation between the cavernous sinus and the internal carotid artery. You got it at the end, but you take more times, which you will not find in the exam. Okay.
Yes, sir.
So try to be more rapid. Try to be if the examiner told you look at the orbit, look at the sinuses, you have to make your mind work more and more to get the idea what could be the case. He will not give you in the exam case of simple fracture or hemosinus or something like this. The case should be has an idea to test you about the management and about the case. Okay.
Yes, sir.
Next candidate, you did it very well. This case should be diagnosed by the history. Okay.
Yes.
I told you the patient post CS. You have to concern about preeclampsia and
Yes, sir. I missed
hyper.
the history. Yes.
What?
Yes, sir. I didn't clearly hear the history. Yes.
Yes,
That's a
this
mistake.
common mistake in the exam. Okay.
Yes, sir.
If you didn't hear the history or anything the examiner told you, gently, please, can you repeat the history, please?
Yes.
I didn't hear the history well, you know. So because you will be evaluated in the exam for clinical reasoning. How you will reason the case without knowing the history. Okay, don't ignore this, and all of us mostly forget the history. No, concentrate in the exam, please. Listen well to the examiner. If you even while you are scrolling through the case and you forget the history, no problem. Ask him again. You will lose the case or lose some marks because you ask him about the history. Okay.
Yes, sir.
So try to listen with because some cases will come straightforward and not all the exam cases will be difficult or case story or like this. Maybe some straightforward cases, but it will need you to listen good to the examiner. And this case of press. Other differential you can put Adam, but less likely you can put glyomatosis cerebri, but less likely because the history of the patient, and you told the management well, you have to control the hypertension. And by the way, they did follow up for this case after 1 month. And if you look at the flare images, it resolved it completely.
Okay, yes.
So it confirmed as a case of breast, but all over you did well the case and you reached the diagnosis and just 1.2. And here we are learning how to deal with the cases in the exam. Okay.
Yes. Thank you.
Thank you. Next candidate.
Yes, sir.
Yes, in your case, I thought it is an easy case. Also, you have to check hidden areas. Okay. You feel some abnormality here. You told, yes, you should, okay. If you are not sure, I can see some abnormality, maybe intraaxial, maybe extraaxial, but you have to look at the mastoid air cells on both sides. In every patient, you have to look at the orbits. You have to look at the sphenoid sinuses and the maxillary sinuses. You have to look at the vessels. You have to look at the optic nerve, superior salving veins. All this you have to look at the foramen magnum. You did it at the end, but you take more time to reach the stress area on the left mastoid air cells. And if you found abnormality in the mastoid air cells on the soft tissue window like here, and you found collection, so you have to go directly for the bone window. You take more time to ask for the bone window, and you ask it for post contrast first. You have to ask for the bone window. Bone window, there is opacification and erosion of the mastoid air cells and middle ear cavity. You have to comment on the middle ear about malleus and incus. The other side, some opacification but no erosion. So directly, you have to suspect infection. An infection. If the patient on the, you have to tell the examiner, if the patient on the table, I will do CT with contrast. If the patient left the department, I will bring the patient again urgently to do MRI with contrast. Okay.
Okay.
Here in the CT, okay, it is not like MRI, but it gives you some hints about the enhancement of the collection. Collection is likely to be appears more and be likely to be peripherally enhanced. You did well because, and there is enhancement here and enhancement here. Okay, you did well that you want to comment on the sinuses. It is very important. Even after contrast, okay, I to take this patient further for more accurate diagnosis because it is an urgent case and management will be surgical. I need to do MRI for better characterization for this patient. He will ask you what you will do, what you will search for in the MRI. He will tell you two things. I will go for the contrast and diffusion. Okay.
Okay.
Yes, in the diffusion you have diffusion restriction. I just want to show you. Yes, there is something here in the ventricle. Okay.
Yes.
There is restricted areas and all the region. So it is this emergent case. They have to go for drainage. There is also suspicious of thrombosis. Yes, venous sinus thrombosis. So you have to be more rapid. You have to go for also the same like previous candidate. You have to do your brainstorming. What should be what I am looking for like this, because no more time in the exam. You have 5 minutes to finish the case. I didn't put timer in our session because still you have 2.5 months or more for the exam. So you have to, in these sessions, you have to take time. But before exam, no one, I will, and if I did session for you, I will not let you to go take this time to reach the diagnosis. Okay.
Okay.
Thank you.
Thank you.
Next one. You did well because you suspect intracranial hypotension because you went for the check areas. There is here the clue is foramen magnum crowding. Here there is the venous sinus is convex, which means it is engorged. And if you look at the internal cerebral veins also engorged. The previous case diagnosis, it was complicated mastoiditis by multiple epidural abscesses and suspected sinus thrombosis. So, and here also the yes, transverse sinus also engorged. If you look here, there is some subdural collection. Okay, so you are suspecting. You did well because you suspect intracranial hypotension, and you did very well by asking for the sagittal, confirmed tonsillar ectopia, and confirmed also pituitary engorgement and loss of the angle between there is sagging of the midbrain also. So the next one will be the post contrast with diffuse pachymeningeal enhancement, and the case was intracranial hypotension. Intracranial hypotension, you have two spontaneous primary, no cause, okay, and there is secondary. The most common cause for secondary intracranial hypotension is CSF leak. You know the which called the Bezos Monroe-Kelly hypothesis that we have three components of the brain: CSF, blood, and brain tissue. Brain tissue is constant. So if there is decrease in CSF, the blood will increase. So there is increase of the epidural vessels, and there is epidural space. And there is also engorged pituitary and distended venous sinus. So I give you the CT myelogram to see the leak. Here there is leak, epidural leak here. Okay, there is intracecal contrast, but there is another epidural, which means there is leak somewhere. Here also there is leak at the atlantoaxial junction posterior going with the nerves. If you look at the coronal, also the brachial plexus will be enhanced, going down. Yes, here there is brachial plexus contrast around the brachial plexus, but in this exam we couldn't detect the site of leak. Okay, there is treatment with which called non-targeted epidural patch. They inject, I think, blood batch inside the cord, but for and also for this case they did isotope scan. They detect contrast leak here. So this was the cause, and the management you have to put non-targeted epidural patch, and also conservative management for the patient symptoms. Next candidate, your case is straightforward. I think we saw the neck infection today, more cases, which are common exam cases, by the way. Maybe retroperitoneal, prevertebral, retropharyngeal abscesses, and there is gas loculi here, and there is collection peripheral enhanced and extending medial to the carotid space down here and there. So most important thing here to look for the airway, and this case also, if the airway is compromised, you have to urgently tell the anesthetist to come to maintain the airway. They can insert in tracheal tube, or if there is patient is advanced, they can do tracheostomy tube. Okay, and this patient may need surgical intervention or interventional radiology for drainage of this abscess, but I think it will need surgical management. Okay. Candidate did very well. Yes, left palatine tonsillitis. There is a lesion here at the area of the Meckel's cave. But if you see here the course of the trigeminal nerve on the left side, you did very well because you asked for the heavy T2 sequence. You can detect trigeminal nerve here, but here you couldn't detect the trigeminal nerve. So this is the most common location for trigeminal schwannoma. Also, trigeminal schwannoma is maybe the part of NF2. So you have to tell the examiner, I will ask for any associated other schwannomas or other meningiomas or ependymoma to exclude NF2. Also, we told that meningioma is a good differential in this region, but it is a typical location of trigeminal schwannoma, and